Having used Oncotype DX for my invasive cancers for over 6 years, the natural progression to the DCIS recurrence score was really quite easy because I understood the underlying biology that was involved. I understood the validation studies. I understood the 16 genes and the 5 recurrence genes. And I know that the Oncotype DX works. DCIS is sort of a different animal because it's very wide-ranging. It can be a 3 millimeter or 4 millimeter focus of DCIS, which is found incidentally on a screening digital mammogram. It can be an extensive disease throughout the breast. But unfortunately, as happens, our radiation oncology friends seem to want to treat everybody the same. They want to treat every patient with DCIS as though they're the same disease, and they clearly are not. Standard of care in the United States has always been to do a lumpectomy or an excisional biopsy, a resection of the DCIS, and then use radiation therapy in therapeutic doses to treat the remainder of the breast. And although sometimes radiation therapy looks great and the results are excellent, sometimes they really are not so good. It's gotten to the point that even in some young patients, young women have chosen to undergo a mastectomy with the diagnosis of DCIS simply to avoid the radiation therapy. And that's really pretty amazing that women would undergo bilateral mastectomies for a disease that has 100% survival. I mean, pretty much no one really dies from DCIS. So when the assay came out that allowed us to finally differentiate those patients who really needed radiation therapy from those who don't really need it or may not need it, obviously once I saw the validation studies that were presented at ASCO, at San Antonio in December, I was very happy to see the assay be released later in December. And we've been using it and been very pleased with it. It gives us a lot of information. First, it gives us a recurrence score, which is a number that we're used to working with and something that we understand. Secondly, it'll reflect the in-breast incidence of recurrent disease, either in situ or invasive, all comers. And it also gives us another validation score of what the risk of an invasive cancer arising in that breast. Between those two scores, we can then apply the same concepts of making recommendations to patients based on science and biology, because after all, that's what we treat. We treat biology. So we've been very happy with it. Patients like it a great deal. They have a comfort level with it, and we've been able to really incorporate it into our overall care of patients.
Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
about personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.